Hello class, this is Emergency Care and Transportation of the Sick and Injured. Chapter 36, Patients with Special Challenges. In this chapter, we will discuss applying fundamental knowledge of growth, development, and aging and assessment findings to provide basic emergency care and transportation for a patient with special needs. And as I just stated, this very statement. This will also, of course, apply to geriatric populations and people with developmental disorders, etc. We will also be dealing with patients with other special challenges and the healthcare implications of things like homelessness, poverty, bariatrics, and technology dependency. We will also be talking about managing care for people who are in hospice or who are terminally ill, tracheostomy care and dysfunction, home care, sensory deficit or loss, and development disability. Now, as far as trauma is concerned, trauma applies fundamental knowledge to provide basic emergency care and transportation based on assessment findings for an acutely injured patient. Now, this is the broad definition of trauma and applies to any and all age groups. Trauma is trauma, but there are special considerations you have to take into account when dealing with geriatric patient or patients with other particular specialized needs. But as far as the broad definition of trauma, this is it. Trauma applies fundamental knowledge to provide basic emergency care and transportation based on assessment findings for an acutely injured patient. Some special considerations in trauma: pathophysiology, assessment, and management of trauma in the cognitively impaired patient. And today, more people with chronic diseases live at home, which means shorter hospitalizations. That in part has brought this about, and also improvements in medicine and technology has helped also bring this about. So people don't have to stay in the hospital as long. They can get equal care in the comfort of their own home. Now, with patients with special challenges, you have patients with diseases resulting in altered bodily function and patients with sensory deficits. And then you also included in that group are geriatric patients with chronic diseases. Some people living at home depend upon mechanical ventilation, intravenous pumps, and other devices. Do not allow yourself to be distracted by the noise and mechanics of the medical equipment. Your focus needs to remain on the patient at all times. Focus on their ABCs. If the emergency is the result of mechanical failure, use equipment, ambulance, or ambulance equipment, or the family's go bag. Now, sometimes you're going to be dealing with intellectual disability. This can be developmental disability, which refers to insufficient development of the brain resulting in some level of dysfunction or impairment. It can include intellectual, hearing, or vision impairments that surface during infanthood or sometimes later in childhood. Intellectual disability results in the inability to learn and socially adapt at a normal developmental rate. Some possible causes of intellectual disability can include genetic factors, congenital infections, complications at birth, malnutrition, environmental factors, prenatal drug or alcohol use, traumatic brain injury, or poisoning, e.g. with lead or other toxins. Some characteristics of a patient with a slight intellectual impairment may present as the following. They may appear slow to understand or have a limited vocabulary. They may behave immaturely compared to their peers. And if severely disabled, they may not have the ability to care for themselves, communicate, understand, or respond to surroundings appropriately, if at all. You must rely on patients and family members for information as to understanding how well the patient can understand you, understanding how well the patient will interact with you, and also to help gain additional medical information regarding the patient, such as patient anxiety. The patient may have difficulty adjusting to change or a break in routine. The patient may also become more difficult to interact as anxiety increases. Make every effort to respect the patient's wishes and concerns. Taking as much time as necessary to explain in a calming, understandable way the treatment that the patient is about to receive is very beneficial for them. Patients with intellectual disabilities are susceptible to the same diseases as other patients, so bear that in mind. Physiologically, they bear no less chance of certain types of illness than anyone else. Autism spectrum disorder is a general term used to describe a group of complex disorders of brain development that vary greatly in signs and symptoms. It is a pervasive developmental disorder characterized by impairment of social interaction, and some other characteristics include severe behavioral problems, repetitive motor activity, and impairment in verbal and nonverbal skills. The patient may also be hyper or hyposensitive to sensory stimuli and may show their pain in unusual ways, such as humming, singing, and removing clothing. Patients with autism tend to display a wide spectrum of disability. Some patients are independent, while others are unable to care for themselves at all. Patients have difficulty using or understanding nonverbal means of communication. That's why, for example, sometimes you'll see autism patients who are perfectly capable of hearing but will use sign language. They frequently have difficulty making eye-to-eye contact, so do your best with simple one-step directions. And they also can tend to have trouble answering open-ended questions, so bear that in mind. And they may speak in robotic or monotone speech patterns and may repeat phrases over and over again. They may also confuse pronouns, e.g. say you when they really mean I, or they may not speak at all. Approximately 1 in every 68 American children is diagnosed with some form of autism disorder somewhere on the spectrum. It affects males 5 times more than females and is typically diagnosed by 3 years of age. Children with autism receive special instruction and care in school-based settings. It is likely that some older adults with autism have never been diagnosed nor received any assistance. Patients with autism generally do not have other medical disorders and will have medical needs similar to their peers without autism. Rely on parents or caregivers for information and keep them involved in the patient's treatment. Explain what you are going to do before you do it. Move slowly, stay calm, and perform physical examinations from distal to proximal. Demonstrate the examination on a parent or a caregiver first to show the patient what he or she can expect. Now let's discuss Down's syndrome. It's written here as Down syndrome, but most correctly it is Downs, D-O-W-N apostrophe S, Downs syndrome. You'll see it written both ways, but according to the Oxford English Medical Edition, it is Downs syndrome. Either way, it's the same syndrome. I just wanted you to be prepared because you will see it written and spoken both ways. Down's syndrome is characterized by a genetic chromosomal defect that can occur during fetal development, resulting in mild to severe intellectual impairment. Increased maternal age and a family history are known risk factors for this condition. Associated physical abnormalities and conditions are a round head with a flat occiput, enlarged protruding tongue, slanted wide-set eyes, and folded skin on either side of the nose, covering the inner corners of the eye. They have short, wide hands, small face and features, and congenital heart defects. There are also thyroid problems, hearing and vision problems, misalignment of teeth and other dental abnormalities, speech abnormalities, and epilepsy. Increased risk for medical complications with Down syndromes include the following. As many as 40% may have heart conditions and hearing and vision problems. Intubation may be difficult due to large tongues and small oral and nasal cavities. Mask ventilation can be challenging because jaw thrust maneuver or a nasopharyngeal airway may be necessary. Management of seizures is the same as for any other patient with seizures, as discussed in Chapter 17, Neurologic Emergencies. In approximately 15% with Down syndrome, the atlantoaxial joint, where the first two vertebrae meet, is unstable. Atlantoaxial joint or atlantoaxial instability, or AAI, is present, and most patients, however, do not show symptoms. There is an increased risk of complications when they experience trauma, however. Now, with patient interaction, it is normal to feel somewhat uncomfortable when initiating contact with a developmentally disabled person. Treat the patient as you would any other patient. Approach the patient in a calm, friendly manner, watching for signs of increased anxiety or fear. Have the members of your team hold back slightly until you can establish a rapport with the patient. Introduce the team members and explain what they're going to do. Move slowly but deliberately, explaining beforehand what you're going to do, just like you would with any other patient. Watch carefully for signs of fear or reluctance from the patient. Make sure you are at eye level with the patient at all times. Do your best to soothe the patient's anxiety and discomfort as you work through your assessment and provide treatment. By initially establishing trust and communication, you will have a much better chance for a successful outcome. Now let's discuss brain injury. Patients with a prior brain injury may be difficult to assess and to treat. Take the time to speak with the patient and family to establish what is considered normal for the patient. Talk in a calm, soothing tone, and watch the patient closely for signs of anxiety or aggression. Do not expect the patient to walk to the ambulance or stretcher. Treat the patient with respect, use his or her name, explain procedures, and reassure the patient throughout the process. Now, there may be sensory disabilities that you're contending with as well. Some possible causes may be a congenital defect, disease, injury, degeneration of the eyeball optic nerve or nerve pathway. The degree of visual impairment may range from partial to total. Some patients lose peripheral or central vision, and some can distinguish light from dark or discern general shapes. Visual impairments may be difficult to recognize. Look for signs that the patient is visually impaired, such as glasses, cane, or a service animal. Now let's discuss visual impairment. With patient interaction who has visual impairment, make yourself known when. Now let's discuss transport considerations. The patient may use a cane or a walker, so be sure to take it with you. A service animal can remain with the patient and will provide reassurance for the patient and prevent delays in transport. However, in some cases, you may need to make arrangements for the animal to be accompanied with the patient. An ambulatory patient may be led by a slight touch on the arm or elbow of the patient, or they may rest his or her hand on your shoulder. You may ask the patient which method they prefer to use. Patients should be gently guided but never pushed or pulled, and obstacles need to be communicated in advance. Now, you may be dealing with hearing impairment. An impairment can range from a slight hearing loss to complete and total deafness. Patients may have difficulty with pitch, volume, and speaking distinctly. Patients may learn to speak even though they have never heard sounds. And patients may have since sustained partial or total hearing loss, leading them to speak loudly. Many older people will have some degree of hearing loss. Most common forms of hearing loss include sensorineural deafness, nerve damage, or the result from a lesion or damage to the inner ear. They may also have conductive hearing loss, which is caused by a faulty transmission of sound waves, and it may be caused by an accumulation of wax within the ear canal or a perforated eardrum. Clues that a person could be hearing impaired are presence of hearing aids, poor pronunciation of words, failure to respond to your presence or questions. Some issues with communication include hearing devices. If this is the case, assist the patient with finding and inserting any hearing aids. Face the patient while you communicate, and do not exaggerate your lip movements or look away. Position yourself approximately 18 inches directly in front of the patient. Do not speak louder, and try lowering the pitch of your voice. Most people who are hearing impaired have learned to use body language, e.g. hand gestures and lip reading. Ask the patient, how would you like to communicate with you? With American Sign Language, they may use an interpreter, family member, or a friend. If an interpreter is not readily available, call your receiving facility early on to request one. As a byline, I would highly recommend that each and every EMT learn how to use American Sign Language. It's used through all of North America and is extremely useful on the job. Now, some helpful hints for communication. Speak slowly and distinctly into the less impaired ear, or position yourself on that side. Change speakers to someone with a low-pitched voice. Provide paper and pencil so you may write your questions and the patient may write responses. Only one person should ask interview questions to avoid confusing the patient. Try the reverse stethoscope technique, which put the earpieces of your stethoscope into the patient's ear and speaks softly into the diaphragm of the stethoscope. The figure on this slide shows terms in American Sign Language related to illness and injury. A is sick, B is hurt, and C is help. Now with hearing aids, these are devices that make sounds louder, and they may be either external or internal, and there are several types available. There's a behind the ear type that's contained in a plastic case that rests behind the ear, a conventional body type, which is an older style used for profound hearing loss, and an in the canal and completely in the canal type. These are contained in a plastic case that fits partially or completely inside the ear canal. In the ear type is contained in a shell that fits in the outer part of the ear. Implantable options are also available. The device should fit snugly, and if you hear whistling, the hearing aid may not be in far enough. If the hearing aid is not working, then help the patient to try to troubleshoot the problem. The figure on this slide shows different types of hearing aids. Behind the ear is A, conventional body is a B type, in the canal is C, and D and E are in the ear types. Now, as far as cerebral palsy is concerned, this is another physical disability you may encounter. Cerebral palsy is a group of disorders characterized by poorly controlled body movement. The possible causes are a result of damage to the developing fetal brain while in utero, oxygen deprivation at birth, and traumatic brain injury at birth. Infections such as meningitis during early childhood can also cause cerebral palsy. The symptoms can range from mild to severe and can vary from poor posture to uncontrolled spastic movements of the limbs, and can also create visual and hearing impairments, difficulty communication, epilepsy or seizures, intellectual disabilities, unsteady gait, which is also called ataxia, which may be necessary for the patient to use a wheelchair or a walker. Make sure you observe the airway closely in a cerebral palsy patient. The patient may have increased secretion of production and difficulty swallowing, dysphagia. It may require aggressive suctioning to clear the airway. Some important considerations are: do not assume that the patients have an intellectual disability. Limbs are often underdeveloped and prone to injury. Patients who have the ability to walk may have ataxic or unsteady gait and are prone to falls. If the patient has a specially made pillow or chair, the patient may prefer to use it during transport. Pad the patient to ensure his or her comfort. Never force a patient's extremities into any type of position. Whenever possible, take walkers or wheelchairs along during transport. Be prepared for a seizure and keep suctioning devices readily available. Spina bifida. This is a birth defect caused by incomplete closure of the spinal column during embryonic or fetal development. The spinal cord is exposed, and the opening can be closed surgically, but it often leaves a spinal and neurologic damage. Some associated conditions with spina bifida are hydrocephalus, which requires the placement of a shunt to drain excessive amounts of cerebrospinal fluid from the brain, and it may also include partial or full paralysis of the lower extremities. There can be loss of bladder and bowel control, extreme latex allergy, And make sure to ask parents or caregivers how to best move them before you try to transport them. Now let's discuss paralysis. Paralysis is the inability to voluntarily move one or more body parts. Some possible causes include stroke, trauma, birth defects, or the patient may have normal sensation or hyperesthesia, which is increased sensitivity. Facial paralysis may also include communication challenges. The diaphragm may not function correctly, requiring the use of a ventilator. Patients may have specialized equipment such as urinary catheters, tracheostomy tubes, colostomy tubes, feeding tubes, and patients may have difficulty swallowing, creating the need for suctioning. Each type of spinal cord paralysis requires its own equipment and may have its own complications. Always take great care when lifting or moving a paralyzed patient. Ask patients or caregivers how to best move them before you transport them. Bariatric patients is our next topic of discussion. Obesity is a condition in which a person has an excessive amount of body fat, the result of an imbalance between calories consumed and calories used. Causes of obesity are not completely understood. It may be attributed to a low metabolic rate or genetic predisposition. The term obese is used when someone is 30% or more over his or her ideal body weight. Severe obesity is when a person is 2 to 3 times over the ideal weight. Quality of life may be negatively affected by obesity. Some associated health problems may be including mobility difficulties, diabetes, hypertension, heart disease, and stroke. Interaction with patients with obesity issues may be difficult. Patients may be embarrassed by their condition or be fearful of scorn as a result of past experiences. If transport is necessary, plan early for extra help and or specialized equipment. Send a member of your team to find the easiest and safest exit. Do not risk dropping the patient or injuring a team member by trying to lift too much weight. Interaction with patients with morbid obesity involves the following. Make sure to treat the patient with dignity and respect. Ask your patient how it is best to move him or her before attempting to do so. Avoid lifting the patient by only one limb, which would risk injury to overtaxed joints. Coordinate and communicate all moves to all team members prior to starting a lift. If the move becomes uncontrolled at any time, stop, reposition, and resume. Look for pinch or pressure points from equipment because this could cause significant soft tissue injury or deep venous thrombosis. Large patients may have difficulty breathing if you lay them in a supine position. There are many types of specialized equipment for morbidly obese patients, and some areas have specifically equipped bariatric ambulances for such patients. Become familiar with the resources available in your area. Plan egress routes to accommodate large patients, equipment, and the lifting crew members. Notify the receiving facility as early as possible. Patients with medical technology assistance are one thing you need to take into consideration. Tracheostomy tubes are tracheostomas which provide a path between the surface of the neck and the trachea, and a stoma is kept open by a plastic tracheostomy tube. It can be temporary or permanent, and it passes from the neck directly into the major airways. For patients who depend on home automatic ventilators, have chronic obstructive pulmonary medical conditions, or tubes that bypass the nose and mouth. Tubes are prone to become obstructed by mucus plugs or foreign bodies, obstructions of the tracheostomy tubes are emergency events, so bear that in mind. A DOPE mnemonic or DOPE mnemonic helps to recognize the cause of obstruction. Displacement, dislodged, or damaged tube is D. O is obstruction of the tube with secretions, blood, mucus, or vomitus. Pneumothorax is P. And E is equipment failure, such as kinked tubing, ventilator malfunction, or an empty oxygen supply. Some common problems with tracheostomy tubes may include bleeding or air leaking around the tube. The tube can become loose or dislodged. The opening around the tube may become infected. As far as management goes, maintain an open airway. Suction the tube if necessary to clear a mucus plug. Maintain the patient in a position of comfort. Administer supplemental oxygen and provide transport to the hospital. With mechanical ventilators, these are used when patients cannot breathe without assistance. Some possible causes could be a congenital defect, chronic lung disease, traumatic brain injury, muscular dystrophy, and disease processes that can weaken the ability to breathe and require a permanent tracheostomy and mechanical ventilator. If the ventilator malfunctions, remove the patient from the ventilator. Apply a tracheostomy collar. It's designed to cover the tracheostomy hole and has a snap that goes around the neck. It may not be available in a pre-hospital setting, but it can be improvised by placing a face mask over the stoma. Patients require assisted ventilation throughout transport. The patient's caregivers will know how the mechanical ventilator works. Caregivers can help you attach the bag and valve from a BVM to the tracheostomy tube. Now let's talk about apnea monitors. These are used for infants who are premature and have a severe gastroesophageal reflux that causes choking episodes. Often there is a family history of sudden infant death syndrome. They have experienced an apparent life-threatening event, and these are used for 2 weeks to 2 months after birth to monitor the respiratory system. Monitor sounds an alarm if the infant experiences bradycardia or apnea. Attached with electrodes or a belt around the infant's chest or stomach is how the actual device is attached. It will provide a pulse oximetry reading that will assist you in assessing the patient's respiratory status. If possible, bring the apnea monitor to the receiving hospital with the patient. Now let's talk about internal cardiac pacemakers. These are devices that are implanted under the patient's skin to regulate the heart rate. They're typically placed on the non-dominant side of the patient's chest, or for small or extremely thin patients, in the abdomen. Pacemakers may also include an automated implanted cardioverter defibrillator to monitor the heart rhythm. Never place a defibrillator paddle or pacing patches directly over the implanted device. Gather information about the cardiac pacemaker while you obtain the patient's history. Some patients will have a pacemaker identification card in their wallets containing information about their particular device. Now let's talk about left ventricular assist devices. These are a special piece of medical equipment that takes over the function of one or both ventricles. They're typically used as a bridge to heart transplantation while a donor heart is being located. They may be a permanent solution for patients who do not qualify for a transplant. Multiple devices are available for adult patients. One device that's approved for use in patients aged 5 to 16 years. Now, it may be difficult to palpate a pulse in patients who use an LVAD, so bear that in mind. Assist perfusion by noting the level of consciousness, skin color, temperature, and moisture. The blood pressure also is an indicator. As far as care, make sure to provide support measures and basic care. Use the caregiver as a resource during the transport. The patient should have a quote-unquote go bag that must be transported with him or her. Be prepared to provide CPR. Contact medical control or follow local protocols. Notify ALS personnel as soon as possible so that other supportive measures may be initiated. Now, there is a device known as an external defibrillator vest. This is a vest with a built-in monitoring electrodes and defibrillation pads, which is worn by the patient under his or her clothing. It's attached to a monitor that provides alerts and voice prompts when it recognizes a dangerous rhythm and before it delivers a shock. It uses high-energy shocks similar to an AED. Avoid contact with the patient if the device warns that it is about to deliver a shock. If the patient is in cardiac arrest, the vest should remain in place while you perform CPR unless it interferes with the compressors, or the compressions rather. Any patient who is wearing a device that has already delivered a shock should be transported to the hospital for further evaluation. Now let's discuss a central venous catheter. This is a catheter that has its tip placed in the vena cava to provide venous access and is used for many types of home care patients that are receiving chemotherapy, long-term antibiotic drug therapy or pain management, total parenteral nutrition or TPN, hemodialysis, and some common locations are the chest, upper arm, subclavicular area also. This figure on this slide shows a central venous catheter. Some common problems with central venous catheters are broken lines, infection around the lines, clotted lines, bleeding around the line or from the tubing attached to the line. So those are some problems that you can encounter with central venous catheters. Now we're going to discuss gastrostomy tubes. These are sometimes referred to as gastric tubes or G-tubes. They're placed directly into the stomach for patients who cannot ingest fluids, food, or medication by mouth. They may be inserted through the nose or the mouth into the stomach using a nasogastric or orogastric tube. They may be placed surgically and may be placed directly into the stomach through the abdominal wall. Here is an example of a gastrostomy tube. The problem with gastrostomy tubes is they may become dislodged during the patient's more normal daily activity. Immediately stop the flow of any fluids and assess for signs or symptoms of bleeding into the stomach. Vague abdominal discomfort may be an issue, and it may be accompanied by nausea, vomiting, especially coffee ground type of emesis, and blood in emesis may also be a problem. With a gastrostomy tube, patients may be at risk of aspiration, so always have suction readily available. Patients with difficulty breathing should be transported while sitting or lying on their right side with the head elevated 30 degrees. Diabetic patients who receive insulin and gastric tube feeding may become hypoglycemic quickly. So unless the tube is dysfunctional, dislodged, or partially dislodged, continue the tube feeding and transport the pump with you. Now we're going to discuss shunts. For patients with chronic neurological conditions, there are tubes that drain excess cerebrospinal fluid, and during assessment you will likely feel a device beneath the skin on the side of the head behind the ear. There could be a fluid reservoir, and that should alert you to the possibility that the patient has an underlying shunt. There are different types of shunts. The ventricular peritoneum shunt drains excess fluid from the ventricles of the brain into the peritoneum of the abdomen. The ventricular atrium shunt drains excess fluid from the ventricles of the brain into the right atrium of the heart. You can have a blocked or infected shunt, and this can produce changes in mental status, and respiratory arrest may also occur. Infections may occur within the first 2 months after insertion, so be sure to obtain a history as to when the shunt was placed and how long it's been there. Some signs of distress with shunts: high-pitched cry or bulging fontanelles in infants, headache, projectile vomiting, altered mental status, irritability, fever, nausea, and there may also be difficulty with coordination, such as walking, blurred vision, seizures, redness along the shunt track, bradycardia, and heart dysrhythmia. The next thing we're going to talk about are vagus nerve stimulators. These are treatments that are used for seizures that are not controlled with medication. These stimulate the vagus nerve at the predetermined intervals to prevent seizure activity. These are used in children older than 12 years of age, and they are located under the patient's skin, about the size of a silver dollar. And if you encounter a patient with this device, contact medical control or follow your local protocols. Colostomies, ileostomies, and urostomies are what we're going to discuss next. Colostomy or ileostomy is a surgical procedure that creates an opening between the small or large intestine and the surface of the body. This allows for elimination of waste products into a clear external bag or pouch, which is emptied or changed frequently. Assess for signs and symptoms of dehydration, especially if the patient has been complaining of diarrhea or vomiting. The area around the stoma is prone to infection, Some signs of infection include redness, warm skin around the stoma, tenderness with palpation over the colostomy or ileostomy site. A urostomy is a surgical procedure that connects the urinary system to the surface of the skin. This allows urine to drain through a stoma into the abdomen wall instead of through the urethra. Contact medical control or follow local protocols for care in the patient with a colostomy, ileostomy, or a urostomy bag. Now let's discuss some of the patient assessment guidelines. Interaction with the caregiver of an adult or a child with special needs is a very important part of the patient assessment process. They have become experts on caring for the patient. Determine the patient's normal baseline status before assessment. Ask specifically, what is different today? Now let's discuss home care. Home care occurs within a patient's home environment. It represents a spectrum of special health care populations: infants, older adults, patients with chronic illnesses, patients with developmental disabilities, and specific services including delivering meals, house cleaning, laundry, yard maintenance, physical therapy, personal care such as bathing and wound care. EMS may be called on to a residence by the home care provider. Obtain baseline health status and history from the home care provider. Hospice care and terminally ill patients are the next subject we're going to discuss. Terminally ill patients may receive hospice care at either a hospice facility or at home with diseases such as cancer, heart and lung failure, end-stage Alzheimer's disease, AIDS, and most patients have a completed Do Not Resuscitate or DNR order. They may have medical orders for a scope of treatment. Now let's discuss palliative care, which is pain care or comfort care. Palliative care or pain management improves the quality of the patient's life before the patient dies and allows the patient to be with family and friends. Follow your local protocols, the patient's wishes, or any type of legal document such as a DNR order. All necessary documentation must be brought to the hospital if the patient is to be transported. It will have a lasting impact on the family, show compassion, understanding, and sensitivity. Ascertain the family's wishes about having the patient remain in the home or having the patient transported to the hospital. If a family member requests to be accompanied with the patient, he or she should be allowed to do so. Follow local protocols for handling the death of a patient. Poverty and homelessness. You are an advocate for all patients. Your job is to provide emergency care and transport, and all healthcare facilities must provide assessment and treatment regardless of the patient's ability to pay. You can be an advocate by becoming familiar with the social services resources within your community. Now let's go over and review everything that we've covered in this chapter. Question 1. Which of the following is a developmental disorder characterized by impairment of social interaction? A. Down's syndrome, B. Autism, C. Cerebral palsy, or D. Spina bifida? This one's in the news a lot, so I'll bet you get this one fairly easily. It is B. Autism. Autism is a developmental disability characterized by impairment of social interaction. Cerebral palsy and spina bifida are physical disabilities, and Down's syndrome is characterized by a genetic chromosomal defect. Since we covered the other aspects of the answer, the incorrect answers, we're not going to review them again here. Just remember that Down syndrome is characterized by a genetic chromosomal defect, and autism is the correct answer. It is a developmental disorder characterized by impairment of social interaction. Cerebral palsy is a physical disability, as is spina bifida. Known risk factors for Down syndrome include smoking, traumatic brain injury at birth, increased maternal age, or D, lack of vitamin B. This one should be fairly obvious. And it is, of course, C, increased maternal age along with a family history of Down's syndrome are risk factors of Down syndrome. The older the egg, or the female zygote, the female egg in a woman, the increased likelihood of Down's syndrome. Let's look at the incorrect answers. Smoking. While smoking is a risk factor for many conditions, it is not known to produce a genetic abnormality known as Down's syndrome. B, traumatic brain injury at birth. TBI is a risk factor of cerebral palsy, not Down syndrome. C, increased maternal age, which we just discussed. The older the female, the more likely she is to produce a child with the genetic malformation that causes Down's syndrome. And D, lack of vitamin B. This is a risk factor for spina bifida, actually, not Down syndrome. Question 3. Which of the following may be difficult to perform on a patient with Down syndrome? A, CPR, B, pulse oximetry, C, splinting, or D, intubation? It is D. Intubation may be difficult because patients with Down syndrome often have large tongues and small oral and nasal cavities. So intubation may be difficult because of these physical changes versus a normal adult airway and tongue size. Let's look at the incorrect answers. CPR. This should not be difficult. The heart's in the same place. CPR is CPR. B, pulse oximetry. This should also not be difficult because they have normal vascular system, so pulse oximetry should not be an issue. C, splinting. This should also not be difficult. And then, of course, D, intubation. That's the correct answer because of an oversized tongue and a decreased size in the overall oral cavity. Number 4, most patients with this disease also have hydrocephalus. Hydrocephalus is A, paralysis, B, Down syndrome, C, spina bifida, or D, cerebral palsy. So most patients with this disease i.e. Down syndrome, also have hydrocephalus. Paralysis, Down syndrome, spina bifida, or cerebral palsy. So let's take a look and see which answer is correct. It is C. Most patients with spina bifida also have hydrocephalus, which requires placement of a stent. This is designed to drain excess CSF from the brain cavity into the abdominal cavity or sometimes into the chest cavity. Let's look at the incorrect answers. To review, number 4, most patients with this disease also have hydrocephalus. A, paralysis. This is not the correct answer. Paralysis does not increase hydrocephalus. B, Down syndrome. This is not the correct answer. Down syndrome does not typically produce hydrocephalus. C, spina bifida. This is the correct answer. It is not uncommon for people suffering with spina bifida to also have hydrocephalus. And D, cerebral palsy, and this again is not the correct answer. Number 5, what does the DOPE mnemonic help you to recognize? A, causes of airway obstruction. B, risk factors for patients using technology assistance. C, questions to ask patients with pacemakers. Or D, a vagal nerve stimulator. Let's take a look. The answer is A. The DOPE or DOPE mnemonic helps you to recognize causes of airway obstruction in patients using technology assistance. Let's look at the incorrect answers. Just to review, number 5, what does the DOPE or DOPE mnemonic help you to recognize? A, causes of airway obstruction. That is the correct answer. B, risk factors for patients using technology assistance. This is not the correct answer. C, questions to ask the patients with pacemakers. Again, this is not the correct answer. And D, a vagal nerve stimulator. Again, that is not the correct answer either. I would suggest reading up on this because it is a little bit of a complicated subject. We certainly are not covering it here strictly in the review question, so please take the time to make sure you have a complete understanding of the DOPE mnemonic and what it helps you to recognize. Question 6. What device is placed directly into the stomach to feed patients? A, colostomy. B, ileostomy. C, gastrostomy tube. Or D, central venous catheter. The answer is C. A gastrostomy tube is used to feed patients who cannot ingest fluids, food, or medication by mouth. So let's take a look at the incorrect answers. Just to review, number 6, what device is placed directly into the stomach to feed patients? A, colostomy tube. This is not correct. This allows for elimination of waste. It is usually attached between the colon and the outside world through use of a colostomy bag that allows the patient to eliminate waste through the colostomy bag. B, ileostomy, and this allows for elimination of waste also, and is not the correct answer here. It's not placed directly into the stomach to feed patients. C, a gastrostomy tube is the correct answer. It is placed directly into the stomach to feed patients. And D, a central venous catheter. This is a venous access device. It has nothing whatsoever to do with digestion. Question 7. What do vagal nerve stimulators do? A. Keep seizures from occurring. B. Keep airways clear from secretions. C. Act as an alternative treatment to medicine. Or D. Both A and C. Let's take a close look at number 7. The answer is D. Vagal nerve stimulators are an alternative treatment to medication for patients with seizures and to keep seizures from occurring. So let's take a look at the incorrect answers. Just to review, number 7, what do vagal nerve stimulators do? A. Keep seizures from occurring. This is one of the 2 correct answers. B. Keep the airway clear from secretion. This is not the correct answer. It doesn't keep the airway clear from secretion at all. C. Act as an alternative treatment to medication. This is one of the other 2 correct answers. So your 2 correct answers are A. Keep seizures from occurring, and C. Act as an alternative treatment to medication. D is both A and C, and of course this is the most correct answer because it accompanies A and C, which are both correct answers. Number 8, an important part of the assessment process for a patient with special needs is to A. Interact with the caregiver. B. Interact with the patient. C. Talk to the manufacturer of the equipment being used. Or D. Transport immediately. The answer is A. Interaction with the caregiver of a child or an adult with special needs will be extremely important. They are trained to use and troubleshoot problems with medical equipment. Not only that, they are the person interacting with the patient and the equipment on a daily basis and literally a minute-to-minute basis. So they are by far your most important resource in terms of obtaining information about the patient's overall condition and how their equipment is functioning, etc. Let's look at the incorrect answers. Just to review, number 8, an important part of the assessment process for a patient with special needs is to A. Interact with the caregiver. That is a correct answer. B. Interact with the patient. Although this is important, it is more important to talk to the actual caregiver themselves. C. Talk to the manufacturer of the equipment being used. The caregiver will actually be the most important person to help you with the equipment itself, how it behaves, how the patient interacts with the equipment, etc. And D. Transport immediately. Before you transport anyone, it is much more important to talk to the caregiver themselves and find out what is actually going on a minute-to-minute basis with the patient and their daily use of equipment. Question 9. What improves a patient's quality of life shortly before death? A. Home care. B. Hospital care. C. Comfort care. And D. Health care. The answer is C. Comfort care is also called palliative care. Pain medications are provided during a patient's last days so he or she can enjoy time with family and friends instead of being overwhelmed by pain and not being able to enjoy their very last moments of life. With proper palliative care, their quality of life is improved in their last few days, and that really underscores the importance of good palliative care. Question 9. What improves the patient's quality of life shortly before death? Let's just review this. Home care. Rationale. Home care may improve the patient's quality of life. B. Hospice care. Hospice care may improve the patient's quality of life. C. Controlled care or comfort care. This is the correct answer. You want the patient to be as comfortable as possible. And D. Health care. This is not the correct answer. The EMTALA Act, or EMTALA Act, states that patients should only be treated if they can pay for care. B. All patients must be treated regardless of their ability to pay for care. C. Only those with serious injuries can be treated without payment for care. And D. Only certain facilities can treat patients who cannot pay for care. Let's take a look at the correct and incorrect answers for this. The correct answer is B. The Emergency Medical Treatment and Active Labor Act, or EMTALA, requires all facilities to assess and treat patients regardless of their ability to pay for care. Let's look at the incorrect answers. The EMTALA Act states that A. Patients should only be treated if they can pay for care. That is incorrect. Not only is it incorrect, it is patently inhumane. B. All patients must be treated regardless of their ability to pay for care. That is the correct answer, and again, the most humane. C. Only those with serious injuries can be treated without payment for care. That is not the correct answer. And D. Only certain facilities can treat patients who cannot afford to pay for care. Again, that is not the correct answer. This is a difficult subject, but please make sure you review it carefully. Measure it against the moral standards and the Hippocratic Oath, and carry that forward with you as you move forward in the profession. Thank you for your time and attention as always, and we'll see you next chapter.